Understanding birth, trauma-related intracranial hemorrhages, requires recognizing that these represent a fundamentally different category of bleeding than the prematurity-related hemorrhages we often encounter in preterm infants. When we discuss birth trauma bleeding, we're examining the consequences of mechanical forces applied during the delivery process, which creates distinct patterns of injury with different risk factors and outcomes. The distinction between birth trauma and prematurity-related bleeding becomes clinically important when you consider epidemiology and management. Birth trauma hemorrhages primarily affect term infants and result from mechanical trauma during delivery, while prematurity-related bleeding like germinal matrix hemorrhage occurs in preterm infants due to vascular immaturity and hemodynamic instability. Subdural hemorrhage represents the most clinically relevant birth trauma bleeding pattern. Evidence from the California Perinatal Database demonstrates the clear relationship between delivery method and hemorrhage risk. Spontaneous delivery carries a 1 in 1900 risk, vacuum extraction increases this to 1 in 860, and forceps delivery carries a 1 in 4 risk. These numbers reflect the significant mechanical forces transmitted to fetal tissues during instrumental deliveries. Primary subarachnoid hemorrhage also occurs from delivery trauma, though it typically follows a much more benign course. Understanding these bleeding patterns helps you recognize when delivery-related mechanical forces have caused intracranial injury, guiding both immediate management decisions and long-term monitoring strategies. Intracranial hemorrhages represent bleeding that occurs within the skull, creating different challenges than the extracranial conditions we just reviewed. The key to approaching these conditions lies in recognizing that location determines everything about clinical behavior and significance. 4 main types exist based on anatomical compartments. Subdural hemorrhage occurs between the dura and arachnoid membranes. Subarachnoid hemorrhage develops between the arachnoid and pia mater. Intraventricular hemorrhage affects the brain's fluid-filled ventricles. Intraparenchymal hemorrhage involves bleeding directly into brain tissue itself. The most important concept for clinical practice involves how gestational age determines hemorrhage patterns. Preterm infants predominantly develop intraventricular bleeding due to immature brain structures that remain vulnerable until approximately 34 weeks gestation. Term infants face different risks, with subdural and subarachnoid hemorrhages representing the primary concerns, typically related to birth trauma and delivery complications. Clinical significance varies dramatically across this spectrum. Some intracranial hemorrhages resolve completely without intervention or long-term effects. Others represent true medical emergencies requiring immediate recognition and aggressive management to prevent permanent neurological damage or death. This range of outcomes makes early recognition essential for appropriate clinical response. The initial presentation often appears subtle, requiring systematic evaluation to distinguish between conditions that need only observation versus those demanding immediate intervention. The following slides will examine each type in detail, focusing on the specific recognition patterns and management approaches that optimize outcomes for affected infants. Epidural hemorrhage represents the most immediately life-threatening form of intracranial bleeding in neonates, though fortunately it occurs in less than 1% of all neonatal intracranial hemorrhages. The rarity should not diminish our vigilance, because when epidural bleeding does occur, the clinical window for successful intervention measures in hours rather than days. The anatomical location creates the emergency. Epidural hemorrhage develops in the potential space between the skull bone and the tough outer layer of the dura mater. This space normally contains no blood or fluid, existing only as a potential cavity. When bleeding occurs here, blood accumulates against the brain with no natural pathway for decompression, creating immediate and progressive mass effect. The mechanism in neonates almost invariably involves skull fractures that tear the underlying blood vessels. Linear fractures can disrupt the smaller meningeal vessels, while depressed fractures create more extensive vascular injury. Temporal bone fractures present particular concern because they can tear the middle meningeal artery, a vessel large enough to produce rapid, life-threatening hemorrhage. The rigid neonatal skull, while protecting the brain during normal activities, becomes a liability when bleeding occurs within this confined space. The clinical presentation in neonates differs significantly from the classic description seen in older children and adults. The famous lucid interval, where patients initially appear well before deteriorating, rarely occurs in newborns. Instead, neonatal epidural hemorrhage typically presents with nonspecific signs that can easily be attributed to other conditions. Apnea episodes, bradycardia, temperature instability, and feeding difficulties may represent the only initial clues. As bleeding continues, seizures often develop, followed by progressive neurological deterioration, including altered consciousness and abnormal posturing. The risk factors center on delivery complications that create sufficient mechanical force to fracture the neonatal skull. Difficult instrumental deliveries, particularly high forceps applications or multiple vacuum extraction attempts, can generate the forces necessary to cause temporal bone fractures. Large for gestational age infants face increased risk because their size creates greater resistance during passage through the birth canal, increasing the likelihood of traumatic delivery. Prolonged second-stage labor with significant fetal head molding also increases fracture risk, especially when followed by rapid delivery that suddenly releases the pressure forces. Imaging provides definitive diagnosis when epidural hemorrhage is suspected. CT scan reveals the characteristic lens-shaped or biconvex hyperdense collection that appears distinctly different from other types of intracranial bleeding. The collection typically shows mass effect with midline shift, reflecting the space-occupying nature of the blood clot. Associated skull fractures appear in 95% of cases, making the absence of fracture strong evidence against epidural hemorrhage. Managing epidural hemorrhage in the neonatal period presents unique challenges that stem primarily from the extreme rarity of this condition. When we encounter fewer than 1% of intracranial hemorrhages falling into this category, we face the fundamental problem of limited evidence to guide our clinical decision-making. This rarity means that even experienced neonatologists may never encounter a case during their careers, making recognition and management particularly challenging. The immediate management priority centers on obtaining urgent neurosurgical consultation, not because we have established protocols to follow, but precisely because we need expert guidance to navigate uncharted clinical territory. Unlike other neonatal conditions, where we have clear management algorithms based on robust evidence, epidural hemorrhage requires individualized decision-making that draws on neurosurgical expertise adapted to neonatal physiology. Medical stabilization follows general principles of neurocritical care adapted for newborns. This approach focuses on preventing secondary brain injury through maintaining optimal physiological conditions. Seizure activity, which can complicate any form of intracranial bleeding, requires prompt recognition and treatment with appropriate anti-epileptic medications. The goal involves creating the most favorable environment possible for the brain, while neurosurgical experts determine the most appropriate intervention strategy. The decision-making process for surgical intervention becomes particularly complex because we lack established neonatal-specific protocols. Adult and pediatric neurosurgical approaches cannot be directly applied to newborns due to fundamental differences in skull anatomy, brain development, and physiological responses. Each case requires careful consideration of the individual infant's condition, the extent of bleeding, associated injuries, and overall clinical trajectory. NICU monitoring takes on heightened importance when managing such a rare condition. Continuous neurological assessment provides the primary method for detecting clinical changes that might indicate progression of bleeding or development of complications. Serial head circumference measurements can detect ongoing bleeding or developing hydrocephalus, though the interpretation of these measurements requires expertise in normal neonatal head growth patterns. Recognition of increased intracranial pressure signs becomes critical, though these may present differently in neonates compared to older children. The outcomes for neonatal epidural hemorrhage remain difficult to predict due to the limited number of reported cases. The project knowledge indicates that clinical outcomes are variable, which reflects both the spectrum of severity that can occur and our limited understanding of prognostic factors specific to this age group. What appears consistent across different types of neonatal intracranial bleeding is that early recognition provides the best opportunity for optimal outcomes, though the specific evidence for epidural hemorrhage remains limited. This uncertainty underscores the importance of long-term follow-up for any infant who survives neonatal epidural hemorrhage. Given our limited understanding of the natural history and optimal treatment approaches, careful developmental monitoring becomes essential to understand both immediate and long-term consequences. This follow-up serves not only the individual patient, but also contributes to our collective understanding of this rare but serious condition. The key lesson for clinicians involves maintaining appropriate clinical suspicion in high-risk scenarios while recognizing the limitations of our current knowledge base. This balance requires us to act decisively when epidural hemorrhage is suspected, while acknowledging that our management approaches are necessarily based on limited evidence and expert opinion rather than robust clinical trials. Subdural hemorrhage in birth trauma occurs when the mechanical forces of delivery tear the bridging veins that traverse from the brain surface through the dura mater to reach the venous sinuses. Understanding this anatomy helps explain both the mechanism of injury and the clinical consequences. Think of bridging veins as delicate structures that must stretch and accommodate the significant deformation that occurs during delivery. These veins normally handle the gradual molding that occurs during labor, but when mechanical forces exceed their tensile strength, they rupture. This rupture causes bleeding into the subdural space, the potential space between the dura mater and the arachnoid membrane. The strong association with instrumental deliveries reflects the physics involved. Vacuum extraction creates negative pressure on the fetal scalp while requiring traction forces to facilitate delivery. When these forces are excessive, prolonged, or applied to an unfavorable fetal position, they can exceed the mechanical limits of the bridging veins. Forceps applications similarly transmit significant forces to the fetal head, particularly during rotational maneuvers needed to correct malposition. Posterior fossa location deserves special attention because this represents the most dangerous form of birth trauma, subdural hemorrhage. The posterior fossa contains vital brainstem structures, and bleeding in this confined space can rapidly lead to brainstem compression and life-threatening neurological compromise. Term infants face higher risk than preterm infants, which initially seems counterintuitive until you consider that term infants undergo more vigorous labor and are more likely to require instrumental assistance due to their larger size and the mechanical challenges this presents during delivery. Evidence shows that precipitous delivery can also cause subdural hemorrhage through rapid decompression and sudden changes in intracranial pressure, while dural tears from excessive cervical extension during breech deliveries represent another mechanism of injury. Clinical recognition of subdural hemorrhage presents unique challenges because these bleeds often occur without visible external trauma to suggest intracranial injury. This absence of external signs means you must maintain high clinical suspicion based on delivery history and neurological presentation rather than relying on obvious physical findings. Posterior fossa bleeding creates the most concerning clinical scenario because of the potential for rapid brainstem compression. When bleeding occurs in this confined space, you'll observe acute neurological deterioration characterized by altered consciousness progressing to stupor. The brainstem compression signs include respiratory compromise that may progress to complete respiratory failure, requiring immediate mechanical ventilation. Additional brainstem compression findings include bradycardia, reflecting involvement of medullary cardiovascular centers, abnormal posturing, such as opisthotonos, indicating severe brainstem dysfunction, and cranial nerve abnormalities, including unequal pupils and abnormal eye movements that don't respond to vestibular stimulation. The insidious presentation pattern occurs with smaller bleeds that don't immediately compromise brainstem function. These infants may appear relatively normal initially, then develop subtle signs over days including lethargy, poor feeding, irritability, and respiratory abnormalities. This delayed presentation can lead to missed diagnoses if clinical suspicion remains low. Early recognition becomes critical because neurosurgical evaluation and potential intervention can be life-saving in cases with significant mass effect. The evidence shows that percutaneous needle aspiration can be successful in selected cases, with studies demonstrating good outcomes when performed appropriately in infants with large subdural collections causing increased intracranial pressure. Primary subarachnoid hemorrhage demonstrates how anatomical location determines clinical significance. The bleeding affects normal brain function through a specific mechanism that explains the characteristic seizure pattern. The subarachnoid space contains cerebrospinal fluid that bathes the cerebral cortex. When bleeding occurs here, blood mixes directly with cerebrospinal fluid and contacts the brain's surface. This anatomical relationship explains why seizures become the primary clinical manifestation rather than mass effect. The seizure mechanism involves blood chemistry and brain physiology. Fresh blood rarely triggers immediate seizures. Seizures develop as red blood cells break down over 24 to 48 hours after bleeding. Hemolysis releases iron, potassium, and other cellular contents that irritate the cerebral cortex. These breakdown products create chemical irritation, generating abnormal electrical activity in superficial brain layers. This explains the timing of well baby with seizures syndrome. During the first day, blood remains relatively intact and non-irritating. By the second postnatal day, sufficient hemolysis creates the chemical environment triggering seizure activity. The timing reflects this biological process rather than bleeding progression. 3 clinical syndromes illustrate different degrees of this irritative process. First, minor hemorrhage, where insufficient blood accumulates to create significant irritation, producing minimal or no clinical signs. Small amounts of blood disperse harmlessly within the large cerebrospinal fluid volume. Second, moderate bleeding creates enough irritation to trigger seizures while sparing deeper brain structures. The blood and breakdown products remain confined to the brain's surface, irritating the cortex responsible for seizure generation while leaving intact deeper structures controlling consciousness, feeding reflexes, muscle tone, and basic neurological functions. The brain surface experiences electrical disruption while essential functions in deeper regions continue operating normally. Seizures represent electrical activity occurring at the surface level, but deeper brain regions house the functions needed for normal behavior between seizure episodes. This anatomical separation explains why infants seize dramatically, yet return immediately to normal feeding and behavior once electrical activity subsides. Subpial variants demonstrate this principle, where bleeding beneath the pia mater creates localized irritation, producing focal seizures that begin in specific body regions. Third, massive hemorrhage overwhelms the brain's ability to contain damage to surface structures. These cases typically accompany severe perinatal asphyxia, suggesting bleeding occurs with already compromised brain function. The seizure mechanism results from surface irritation rather than deep brain injury. Seizures develop from chemical irritation of the cortex by blood breakdown products, while deeper brain structures responsible for consciousness and basic functions remain unaffected. This explains the remarkable preservation of normal behavior between seizure episodes and the excellent prognosis for most cases. The condition typically resolves as blood clears and chemical irritation subsides. When evaluating birth trauma-related intracranial hemorrhage, imaging selection significantly impacts diagnostic accuracy. MRI demonstrates superior sensitivity for detecting birth trauma bleeding compared to other modalities, particularly excelling in posterior fossa subdural hemorrhage detection, where most birth trauma bleeds occur. The enhanced sensitivity for parenchymal injury detection makes MRI the preferred first-line technique when clinically stable patients require evaluation. CT maintains clinical utility for rapid assessment in unstable neonates. The 2002 American Academy of Neurology practice parameters specifically recommended CT for neonates with birth trauma presenting with low hematocrit or coagulopathy, based on studies demonstrating CT diagnoses leading to interventions. However, radiation exposure concerns favor MRI when available and patient stability permits. Ultrasound demonstrates significant limitations in birth trauma hemorrhage detection. Cranial ultrasound lacks sensitivity for extraaxial hemorrhages, including subdural and subarachnoid bleeding. The normal increased echogenicity around the brain periphery particularly limits subarachnoid hemorrhage detection. Even when subdural hematomas are detected through mastoid fontanelle imaging, MRI or CT better demonstrate extent and distribution of supratentorial lesions. Clinical context remains essential for accurate diagnosis. Delivery history, including vacuum or forceps assistance, provides crucial risk stratification. Birth trauma hemorrhages often occur without external signs of head injury, requiring high clinical suspicion. Distinguishing primary birth trauma bleeding from secondary extension of intraventricular hemorrhage, cerebellar bleeding, or other hemorrhage sources guides appropriate management decisions and family counseling. Birth trauma intracranial hemorrhage management follows evidence-based principles emphasizing conservative care with selective surgical intervention. Most neonates with subdural hemorrhage can be managed symptomatically with serial hematocrits and vital signs monitored frequently. The blood collection gradually resorbs over weeks to months in most cases, supporting expectant management as the first-line approach. Neurosurgical consultation becomes essential in specific high-risk scenarios. Large subdural hematomas causing increased intracranial pressure or significant mass effect require surgical evaluation. Clinical studies demonstrate percutaneous needle aspiration success rates of approximately 71% based on case series, with successful intervention reported in 5 of 7 infants in one study and 8 infants in another, establishing this as a treatment option for appropriate cases. Posterior fossa bleeding with brainstem compression represents a neurosurgical emergency requiring immediate consultation. These infants present with severe clinical signs, including stupor, bradycardia, respiratory compromise, and altered neurological status within the first 24 hours. The anatomical proximity to vital brainstem structures makes rapid recognition and intervention critical for patient survival. Serial neurological monitoring forms the cornerstone of ongoing management. Head circumference measurements and serial head ultrasounds screen for developing hydrocephalus, particularly important in subarachnoid hemorrhage cases. Seizure management with anti-seizure medications addresses secondary complications when they occur. Supportive care addresses the broader clinical needs of these neonates while allowing natural resolution of hemorrhages. The overall prognosis remains favorable, with approximately 80% of infants with less severe hemorrhages achieving normal developmental outcomes, reinforcing the appropriateness of conservative management in most cases. Facial nerve palsy represents a peripheral cranial nerve 7 injury resulting from mechanical compression during the birth process. The pathophysiology centers on direct pressure applied to the facial nerve as it courses through the temporal bone, particularly at the stylomastoid foramen where the nerve exits the skull. During delivery, compression occurs through several mechanisms. Forceps delivery creates the highest risk, with the forceps blade directly compressing the nerve against the temporal bone. The project evidence confirms that difficult vacuum extraction, challenging forceps, or rotational maneuvers significantly increase birth trauma risk. Maternal pelvic structures can also compress the nerve during prolonged labor or cephalopelvic disproportion, particularly when the fetal head is subjected to unusual deforming stresses. The facial nerve controls both upper and lower facial muscles through its motor branches. Unlike central nervous system facial weakness, peripheral lesions affect the entire ipsilateral face, including forehead muscles. This anatomical distinction becomes clinically crucial for differential diagnosis, as central lesions typically spare forehead function due to bilateral cortical innervation of these muscles. Most cases involve temporary dysfunction rather than permanent nerve damage. The compression typically causes neuropraxia, temporary nerve conduction blockade without structural damage to the nerve fibers. This reversible injury mechanism explains why the majority of birth trauma-related facial nerve palsies resolve spontaneously within weeks to months. Complete nerve transection or severe axonal injury occurs rarely but carries worse prognosis for recovery. Understanding this pathophysiology guides both acute management decisions and prognostic counseling for families facing this concerning but generally temporary condition. Clinical recognition of neonatal facial nerve palsy requires systematic assessment of facial symmetry and function. The project evidence emphasizes the importance of thorough neurological examination, noting that the infant's ability to suck and swallow, the pooling of secretions, the character of the cry, should be carefully assessed in neuromuscular conditions. The most prominent finding involves mouth drooping on the affected side. When the infant cries, facial asymmetry becomes strikingly apparent as the mouth pulls toward the unaffected side, creating characteristic one-sided facial expression. This asymmetric crying represents one of the earliest and most reliable diagnostic signs, often noticed immediately after birth. eye involvement creates significant clinical concern. The affected eye remains partially or completely open due to orbicularis oculi weakness, preventing normal eyelid closure. This inability to close the eye completely predisposes the infant to corneal exposure and potential injury. The eye may appear wider on the affected side, and the infant cannot produce normal blinking responses. Nasolabial fold absence on the affected side provides another key diagnostic marker. The natural crease extending from the nose to the corner of the mouth disappears or becomes significantly flattened compared to the unaffected side. This asymmetry becomes more pronounced during facial expressions. Forehead involvement distinguishes peripheral from central facial nerve lesions. In peripheral lesions affecting the entire facial nerve, forehead wrinkling ability is lost on the affected side. Central lesions typically spare forehead function due to bilateral cortical innervation. Testing forehead movement helps localize the lesion and guide diagnostic considerations. Swallowing difficulties may accompany severe cases, particularly when facial nerve branches affecting oral motor function are involved. Assessment of feeding efficiency and coordination becomes essential for comprehensive management planning. Management of neonatal facial nerve palsy centers on protective measures and supportive care. Multidisciplinary teams, including pediatrics, neurosurgery, ophthalmology, nursing, and other specialists, play a key role in coordinating care. This collaborative approach is particularly important for effective management. Eye protection represents the most critical priority. The inability to close the affected eye completely creates immediate risk for corneal exposure keratopathy. Artificial tears should be applied regularly to maintain corneal moisture and prevent drying. The frequency typically ranges from every 2 hours during wake periods to more frequent application in dry environments. Preservative-free formulations are preferred to minimize irritation with repeated use. Eye patching becomes necessary when conservative measures prove insufficient. Patching protects the corneal surface during sleep periods when natural tear production decreases. However, continuous patching should be avoided during wake periods to prevent deprivation amblyopia in the developing visual system. Regular ophthalmologic monitoring identifies early signs of corneal abrasions or other complications requiring immediate intervention. Feeding support may be needed when facial nerve dysfunction leads to swallowing difficulties. Assessing the infant's ability to suck and swallow is critical, since unrecognized impairment can result in poor nutrition or aspiration risk. Depending on severity, adjustments in technique, positioning, or temporary feeding assistance may be required. Physical therapy offers potential benefits for facial muscle function recovery. Gentle massage techniques and passive range of motion exercises may help maintain muscle tone and prevent contractures. However, active interventions should be delayed until the acute inflammatory phase resolves. No surgical intervention is indicated during the acute phase. The majority of birth trauma-related facial nerve palsies result from temporary compression rather than complete nerve transection, making surgical exploration unnecessary in most cases. Understanding the recovery timeline for neonatal facial nerve palsy provides essential guidance for clinical management and family counseling. Neurological recovery patterns in neonates follow predictable timelines, with most conditions showing improvement within weeks to months when appropriate supportive care is provided. Most cases of birth trauma-related facial nerve palsy demonstrate improvement within 2 to 4 weeks. This timeframe reflects the typical duration required for neuropraxia recovery, where temporary nerve compression causes conduction blockade without permanent structural damage, with most infants recovering within a few weeks. For similar neurological conditions, about 90% of infants recover in less than 2 months. Complete recovery can be expected in the majority of cases. The favorable prognosis stems from the pathophysiology of birth trauma facial nerve injury, which typically involves temporary compression rather than nerve transection. When the underlying mechanism involves reversible injury, full functional restoration occurs as inflammation resolves and normal nerve conduction returns. However, some cases may require several months for complete resolution. Factors influencing recovery duration include the severity of initial compression, the extent of nerve inflammation, and individual variations in healing responses. Prolonged recovery doesn't necessarily indicate poor prognosis, as even cases requiring months may achieve complete functional recovery. Early signs of improvement provide strong prognostic indicators. Initial return of voluntary movement, even if subtle, suggests intact nerve continuity and predicts favorable outcomes. Parents should be educated to observe for gradual improvement in facial symmetry during crying, progressive return of eyelid closure, and restoration of nasolabial fold prominence. Partial paralysis generally carries better prognosis than complete paralysis. When some facial function remains preserved, it indicates less severe nerve injury and suggests more rapid recovery potential. Family education should emphasize the expected recovery course while maintaining realistic expectations about the timeline for complete resolution. Neonatal skull fractures occur when delivery forces overcome the newborn skull's natural flexibility. A large fetal head or a narrow maternal pelvis increases pressure at points of contact, while an unusually compliant skull can deform too much under stress, making fractures more likely. Labor abnormalities also matter. Rapid deliveries don't allow time for gradual molding, whereas prolonged labors expose the skull to sustained compression that eventually exceeds its elastic limit. Malpresentations like breach or face first add irregular force vectors the skull isn't designed to absorb. Instrumental deliveries concentrate pressure into small areas. Forceps can apply rotational torque, and vacuum extractors create suction forces. When these are repeated after failed attempts, damage accumulates. Large infants and coagulation problems further compound risk, either by increasing the load on the skull or by making even minor fractures more clinically dangerous. Maternal trauma, such as blunt abdominal injury, can transmit sudden force directly to the fetal head. Clinically, the challenge is that many fractures are silent at birth. Without recognition, bleeding can progress unnoticed until serious intracranial complications appear. That's why understanding these risk factors is essential, because they point to which infants need closer monitoring, despite looking well initially. Neonatal skull fractures can be hard to recognize, so clinical context is key. Any delivery that was prolonged, required difficult instrumentation, or involved abnormal positions should raise suspicion, even if the head looks normal at birth. Because fractures often lack external signs, systematic examination is essential. Palpating the entire skull may reveal subtle step-offs, while fontanelle tension or abnormal pulsation can signal rising intracranial pressure. Tracking head circumference over time is more reliable than a single measurement for catching evolving complications. Diagnosis relies on tools suited to neonates. Cranial ultrasound through the fontanelles provides excellent first-line imaging without radiation, and MRI offers greater detail when transport is feasible. CT is reserved for acute situations where rapid diagnosis is essential. Most linear fractures heal without intervention, but vigilance is crucial. Complications such as hydrocephalus, intracranial bleeding, or growing skull fractures require early recognition and neurosurgical input. Because of these risks, management focuses less on the fracture itself and more on coordinated monitoring and follow-up between neonatology and neurosurgery teams. Understanding key clinical differentials in birth trauma requires systematic assessment of anatomical relationships and temporal patterns. Birth trauma occurs when infants experience unusual or rapid deforming stresses, such as compression, molding, or extraction forces during delivery, particularly with difficult vacuum extraction, challenging forceps, or rotational maneuvers. The relationship to suture lines provides the most reliable differential diagnostic feature. Caput succedaneum represents superficial soft tissue swelling that readily crosses suture lines because it occurs in the subcutaneous tissue above the aponeurosis. This location allows fluid accumulation to extend across anatomical boundaries, creating diffuse scalp edema that spans multiple cranial bones. Subgaleal hematoma also crosses suture lines due to its location in the potential space between the galea aponeurotica and periosteum. This space extends from the orbital ridges anteriorly to the superior nuchal lines posteriorly, allowing blood to accumulate across the entire cranial vault, regardless of suture boundaries. The anatomical extent explains both its ability to cross sutures and its potential for massive hemorrhage. Cephalohematoma distinctively does not cross suture lines because bleeding occurs between the periosteum and skull bone. The periosteum firmly adheres at suture lines, creating natural boundaries that prevent hemorrhage extension beyond individual cranial bones. This anatomical restriction creates the characteristic well-demarcated swelling limited to single bones. Timeline patterns reflect underlying pathophysiology. Caput succedaneum appears immediately at birth due to pressure-induced fluid extravasation during delivery. Traumatic hemorrhages most commonly manifest within the first 24 hours of life, with cephalohematoma typically developing over this time frame as subperiosteal bleeding gradually accumulates. Subgaleal hematoma demonstrates progressive enlargement over hours to days, representing the most dangerous pattern. Recognition of progressive head circumference expansion, pallor, and hemodynamic instability mandates immediate intervention to prevent exsanguination and circulatory collapse. NICU management of birth trauma demands systematic protocols, ensuring optimal outcomes through evidence-based care delivery. Successful neurological management requires promoting adequate oxygenation, ventilation, circulation, and correction of metabolic derangements as foundational priorities, particularly since birth trauma cases often present as critically ill patients with signs of multi-organ involvement. Systematic assessment forms the cornerstone of birth trauma management. Comprehensive evaluation must include assessment of neurological function from delivery, with particular attention to clinical presentations that may indicate serious injury. Birth trauma cases requiring systematic evaluation include infants with large head and small birth canal proportions, those subjected to difficult instrumental deliveries, and neonates presenting with concerning neurological signs, including stupor, bradycardia, ataxic respirations, facial paresis, or seizures. Early recognition of life-threatening conditions proves essential for preventing mortality and morbidity. Symptoms most commonly occur within the first 24 hours of life, emphasizing the critical need for rapid surgical evacuation in severe life-threatening conditions. Clinical indicators demanding immediate attention include progressive head circumference expansion, hemodynamic instability, and deteriorating neurological status. Appropriate imaging selection optimizes diagnostic accuracy while minimizing patient risk. MRI demonstrates superior effectiveness for comprehensive evaluation, however, CT provides utility for rapid diagnosis in unstable patients. Lateral skull radiographs and cranial ultrasound serve as additional diagnostic tools. The choice depends on clinical stability, with cranial ultrasound serving as the bedside, non-invasive neuroimaging modality ideal for repeated monitoring, though it has limitations for detecting certain types of hemorrhage. Multidisciplinary coordination ensures comprehensive care delivery for complex cases. Birth trauma management often requires coordination between neonatology, neurosurgery, radiology, and nursing teams to address the spectrum of potential complications effectively. Family education and support during acute care provides essential psychosocial foundation. Understanding parental stress and providing clear, accurate information about diagnosis, treatment plans, and expected outcomes helps families navigate the complex acute phase while building trust in the medical team's expertise. Documentation requirements ensure continuity of care and facilitate ongoing monitoring and follow-up assessments, essential for detecting delayed complications and optimizing long-term developmental outcomes. Prevention and risk reduction strategies for birth trauma require evidence-based decision-making throughout the delivery process. Clear statistical relationships exist between delivery methods and birth trauma incidents, providing the foundation for prevention protocols that demonstrate marked differences in intracranial hemorrhage rates. Careful selection for instrumental deliveries represents the primary prevention strategy. Statistical evidence reveals striking differences in birth trauma rates. Spontaneous delivery carries the lowest risk at approximately 1 per 1,900 births. Vacuum extraction increases risk to 1 per 860 births, and forceps delivery further elevates risk to 1 per 664 births. This data demonstrates that instrumental delivery increases birth trauma risk by approximately 2 to 3-fold, emphasizing the importance of judicious selection criteria. Appropriate vacuum and forceps technique with strict adherence to established limitations prevents excessive force application. Difficult vacuum extraction, challenging forceps application, and rotational maneuvers represent significant risk factors for birth trauma. Training programs must emphasize proper technique, appropriate force limits, and recognition of when to abandon instrumental attempts in favor of cesarean delivery. Recognition of cephalopelvic disproportion allows proactive intervention before traumatic delivery attempts. Birth trauma occurs when infants experience unusual or rapid deforming stresses, particularly with large head and small birth canal proportions or unusually rigid pelvic structures. Clinical assessment tools, including pelvimetry, fetal weight estimation, and labor progress evaluation guide decision-making. Timely decision for cesarean delivery, when indicated, prevents prolonged traumatic labor. Birth trauma risk factors include both short duration, labor preventing adequate pelvic dilation, and unusually long labor subjecting the fetal head to prolonged compression and molding. Balanced assessment of maternal and fetal factors guides optimal timing decisions. Gentle delivery techniques for all presentations minimize mechanical stress regardless of delivery route. Atypical presentations, including breech, face, or brow deliveries, increase birth trauma risk. Specialized training in gentle extraction techniques, controlled delivery of aftercoming head and breech presentation, and coordinated team approaches reduce force application. Team communication during complicated deliveries ensures coordinated care and optimal decision-making. Clear communication protocols establish roles, facilitate rapid consultation, and enable seamless transitions between attempted instrumental delivery and emergency cesarean section when clinical situations change rapidly. Birth trauma encompasses a comprehensive spectrum of mechanical injuries resulting from the forces of labor and delivery. These injuries occur when infants experience unusual or rapid deforming stresses, such as compression, molding, or extraction forces during delivery, representing a continuum from benign soft tissue changes to life-threatening hemorrhages requiring emergency intervention. Systematic assessment remains critical for appropriate management across this entire spectrum. Birth trauma incidence has been underestimated because many hemorrhages appear asymptomatic, highlighting the importance of comprehensive evaluation protocols. Clinical assessment must include careful examination for signs of neurological compromise, hemodynamic instability, and progressive deterioration that may indicate serious underlying injury. Differentiation between conditions relies on evidence-based anatomical and temporal patterns. Understanding the relationship to suture lines, timeline of appearance, and associated clinical findings enables accurate diagnosis and appropriate management decisions. Clear distinctions exist between conditions, with some crossing suture lines while others remain confined by anatomical boundaries. Subgaleal hematoma represents the true emergency requiring immediate recognition and intervention. This condition demands rapid surgical evacuation for severe life-threatening cases. The potential for massive hemorrhage and circulatory collapse requires heightened vigilance and immediate multidisciplinary response when clinical indicators suggest progressive bleeding. Most birth trauma conditions demonstrate favorable outcomes with appropriate acute care management. While birth trauma can present with serious symptoms, including stupor, bradycardia, ataxic respirations, facial paresis, or seizures, the majority of conditions resolve with supportive care and careful monitoring. This favorable prognosis reflects both the resilient nature of neonatal physiology and the effectiveness of evidence-based management protocols. Early recognition and intervention prove essential for optimal outcomes across the birth trauma spectrum. Symptoms most commonly occur within the first 24 hours of life, establishing the critical importance of systematic assessment and continuous monitoring during this vulnerable period. Prompt identification of concerning findings, appropriate imaging selection, and timely consultation ensure that serious complications are addressed before irreversible injury occurs. This comprehensive approach to birth trauma management, incorporating systematic assessment, evidence-based differentiation, emergency recognition capabilities, and appropriate intervention strategies, optimizes outcomes for this vulnerable patient population while providing families with the expert care their infants require during this challenging period.